In 1985, IPA came into existence to do the contracting with essentially Tufts Health Plan in a capitated contract, and we were the first group to really organize ourselves to do that. And the way they functioned essentially from 1985 to 1995, the first 10 years, was with essentially no infrastructure at all and really no management. So it was a matter of just a group of docs happening to do reasonable utilization. Part of the reason they were successful was that there were a very solid group of primary care doctors who very carefully managed their patients, and that the IPA was very PCP centric. And I think that culture was part of our existence from the beginning. It really developed based on where we thought our expenses were. So we looked at how much money we were spending in pharmacy utilization, and we realized that it was a big part of our budget, but we weren't managing it all. And then when we got claims data and looked at where we were spending the money within the pharmacy, we realized that a lot of it was because people weren't using generic drugs. And our first pharmacist literally would get claims data, and with a yellow pen and a highlighter go through and pick out drugs that she thought were expensive and could have generically equivalent, significantly cheaper drugs of the same quality and efficacy. And then we would go around and just basically educate our doctors. The culture in that time was such that people were very angry at managed care. The patients didn't like being told that they couldn't go wherever they wanted. But physicians also were very angry at having someone in their office telling them what they could prescribe, what tests they could order. And the culture really developed with time as we really proved to docs that we were, one, helping them deliver higher quality care, and two, that the cost to their patients were less. With radiology, we looked at radiology and said, that's a very high cost to us. And we effectively went to our radiology department, and they started to do reviews of CAT scans and MRIs. So when I, as a primary care doctor, ordered an MRI, they would ask me for clinical information. And if the MRI was not the right test, our radiologist would call up the internist and say, we think an MRI with gadolinium is a better test than one without. Or we think a CAT scan or an ultrasound will get you what you want much better. I think part of what made us successful was that we always went for the right test first, not because it was trying to cut back on expenses, but trying to get the diagnosis quicker. We tried to focus on educating people on for example, with diabetes, what the right meds were, what the right goals were with your hemoglobin A1Cs. So focusing on quality helped get people to accept us in their offices more. We also developed a structure with our primary care doctors where every primary care doctor is organized into a group, and we pay doctors to go to meetings, and we teach them in those meetings. They're monthly meetings. We teach them about various topics. So one month it might be diabetes, years ago it was asthma, and as new therapeutics come in, as new drugs come on the market, we use that as a way of teaching people what the right thing to do. So we have, over the years, we've just developed a culture and a way of communicating with our docs that they accept that we're working for them, not for the health plans, and that we're working for patients. What we've tried to do is do a similar education process with our specialists, so that we may not meet monthly with our specialists, but over the course of a year we try to meet, or over a course of 2 years, we try to meet with certainly the big groups. We try to let them know that we're their advocate as well for issues that may come up. And mostly what we try to do is work with our docs to make sure that everybody's communicating around patient care. That's always been a big issue for specialists, is they don't feel that they get the communication they need from primary care doctors, so they have to reorder tests or do more than they would. And so we've spent a lot of time trying to encourage that. I frequently give an example of a diabetic patient who I tried everything under the sun to get under control and couldn't. And we actually sent a pharmacist out to the house to meet with her, go over all the drugs, had a nurse go out and work with her on her food choices, and do it actually in the home. And about 2 weeks after this program started, I got a very irate call from the daughter who said, you know, my mother can't afford any of this, what are you doing? And I said, but wait a minute, your mother's not paying for any of that. As part of my physician group, it's one of the services we give, because her diabetes is so out of control, it puts her at risk for having a heart attack and a stroke, and her feet aren't doing well and she's going to get an infection, and we're trying to help her to improve her care. We're paying for that. And it was like, oh my God. I don't think we know what the right payment model is. I think that what the right payment model for a small, organized group like ours that's geographically reasonably close works, doesn't mean that it will work for another group of doctors in a different part of the state. I don't think it's clear I don't think we really know what works. And I think there's a lot more to be studied before we go into taking a whole state to global capitation. I know for a group like ours, with appropriately set budgets, with risk adjustment, and with a lot of money being put into infrastructure, I think it can work. The problem is we've had 10 years or 12 years of building that infrastructure, and it's expensive. It's not cheap. So what you have to look at is, what's it going to take to recreate these kinds of programs across other groups? And you can't ask doctors to take their money and put it into the programs and put the effort into doing the management that it takes unless there's more dollars coming their way as well. So you have to offset the cost savings by better care by putting some of that into infrastructure and some of that into paying docs.